the Miller-McEntire Periodontal Prognostic Index clinical application. This is a companion video to the first part, which is the background and development. And I would suggest that you look at that before looking at this video. Additionally, the article published in the February issue of 2014 Journal of Perio can even give you more background information if you are interested. We mentioned the 7 factors that compose the MMPPI, or a term we're going to introduce today, the dental report card. And that's age, smoking, diabetes, molar type, probing depth, furcation involvement, mobility, and the total. Now, 3 of these factors, age, diabetes, and smoking, can be taken off the health questionnaire and can be scored by a dental hygienist or a dental assistant before the dentist ever sees the patient. If the patient is under 40, they score a 0. If they're over 40, a 1. If they have diabetes, then we use A1C levels and we see what those are there. And finally, if the patient is a smoker, since we know that smoking is the most significant etiologic factor, that scores a 4. So let's say the dental assistant is seeing the patient prior to the dentist seeing them, and the age of the patient is a 1, this patient is smoking a 4, and the patient is a diabetic, and they have an A1C score of nearly 8. So therefore, before the patient ever gets seen for the dental findings, they've got a score of a 5, 6, 7, which is a significant negative prognosis. Now let's look at patient 1, and this was very typical of the patients that I saw in practice. So therefore, this is a 42-year-old male, second, smoking a pack of cigarettes a day, that is not diabetic. So therefore, this patient scores a 5 before of any of the dental findings. And this patient has a treatment-focused diagnosis, or a TFD, of severe localized periodontitis in the molar areas. You probably not have heard the term treatment-focused diagnosis, but this is something that can be very instrumental in teaching dental students or your hygienist, or actually looking at the patient yourself, because this tells you exactly where the severity of the disease is and gives you some idea of treatment. For instance, if you say a patient has a periodontitis, you don't know where it is, you don't know how severe it is. But in this patient, a severe localized periodontitis in the molar areas. It does not mention anything about the anterior area, so apparently there's no other periodontal disease in the mouth. And when you see severe localized disease, in all probability, you're going to be looking at surgery, or you're possibly going to lose some teeth. So if you're interested in this, you can go to the video on that and actually look at how to do the treatment-focused diagnosis. Now we come to the other 4 factors: molar type, probing depth, furcation involvement, and molar class. Now, with molar type, we know that the maxillary second molar has the poorest prognosis in the mouth, so that scores a 2 because we're scoring number 15. The probing depth you see here is a 2. We look at a 2 and we see probing depths are in excess of the 8 millimeter range, again confirming that we're dealing with a severe periodontitis. And interestingly enough, we have 2 furcation involvements on that. And remember, this is not the severity of the furcation, just the presence of the furcation. And we do have mobility that we are concerned about, especially with that much periodontal loss. So our total MMPPI score is a 13. And if we look over here at the score sheet here, we find that an 11 is 53%. So this patient that was referred to us to successfully treat has, according to this, a very poor prognosis. But let's see what we can do treatment-wise, as it were, on that. Now, we're doing now what we're scoring here as the target score, or the dental diagnosis for the patient, or the dental prognosis. The patient is going to stop smoking, and you notice when we use a dash, this is in lieu of a 0. It's easier to ignore than a 0. The patient is not diabetic. The molar type remains the same. And yes, we're going to improve the probing depth, and we're going to get these down into the 5 and 6 millimeter range, perhaps not as ideal as we would like to see. The furcations will remain. The mobility is going to be reduced, although we still have some mobility, and now we're down to a 7. And what does a 7 mean? It means the patient has an 86% chance of keeping the teeth for 15 years in health if we follow the keys to success, which we will mention in a minute. And I think this is very impactful when you can share this information with the patient. Here's patient 2. Please pay close attention to what impact lifestyle changes can make on this particular patient. The patient is a 29-year-old female, which means that she's under 40, and that scores a 0 or a dash, as we said earlier. She is smoking 2 packs of cigarettes a day, and obviously that's a no-no. And she says she is not diabetic. So therefore, we're starting out with a score to begin with. But let's look a little deeper. The treatment-focused diagnosis on this patient is a severe generalized gingivitis. That means there's no attachment loss, there's very severe bleeding and so forth and so on, but in all probability this patient would not be referred to a periodontist. This would be treated by a restorative dentist. What are other significant findings? Patient says she's not diabetic. However, her mother and 3 aunts are diabetic. But let's look a little deeper. The patient's mother and 3 aunts are diabetic. So there's a strong family history, and it's gender-related, makes it even more significant. Second, the patient is significantly overweight. Now, given that and the severe gingivitis, mobility, and so forth, you would certainly begin thinking in terms of being a diabetic. However, she does not admit to being a diabetic, says that she's not. What do you do at this point? Well, you've got 2 choices. One, you can stop and refer the patient to the physician, and the patient will get out of your office and be gone a certain period of time before they get back for treatment, in all possibility may not get back. Or you can suggest that they do an A1C in the office, which you can order from Amazon, which costs about $12 to $13 per test. And it is very, very accurate. Personally, I use this myself, given the fact that I'm diabetic. Now, let's look at the other 4 factors: molar type, probing depth, furcation involvement, and mobility. In this case, we're scoring the first molar, which provides 60% function, making it a very key tooth. So if you maintain a first molar occlusion, including the function of the 2 premolars, you have 80% function. Probing depths, we've already said, are not that significant. She has a gingivitis. She has some 5, 6 millimeters swollen gums, maybe an occasional 7, but certainly with no attachment loss. And with no attachment loss, there would be no furcation involvement. However, the patient is diabetic, and what do we know about a diabetic? These patients do have a certain level of mobility, and I would be concerned about that. So we add the figures up, and this patient scores 11. What does 11 mean? The patient has only a 50% chance of keeping her teeth till for 15 years. Does that mean she's going to lose all of them? No. But in all probability, without treatment, she will have lost a tooth or 2, maybe even more, in 15 years. Now, let's talk in terms what we can do with treatment or coming up with a target score or the periodontal report card. Now, we've already given them the periodontal report card. Now let's tell them what the scores are going to be and how well they can do if they follow our treatment recommendation and include the keys to success. The patient, let's say, stops smoking. They don't control the diabetes 100%, but they get it down a little over a 7, and that's going to make a big difference. Because once we ran the A1C score in the office, it was an 8.6, as you can see on the left, and that scored a 3. So we've made a marked impact on smoking. We've made a marked impact on diabetes. Both of these are lifestyle changes that are going to pay tremendous dividends for this patient. And certainly, we're going to be able to get rid of any excessive probing depth given the nature of the disease, the treatment-focused diagnosis, and so forth. And once we do that, we're going to also go in and reduce the mobility. Remember, there are no furcation involvements because this is a gingivitis. So we started with 11, and looky here. We have got it down to a 3. And that's very reasonable treatment if we can motivate the patient, and using the MMPPI and talking in terms of the dental report card can have a marked impact on that. So we get her down to a 3. She loses weight, her breath is better, and the chances of getting in a relationship are much better. We can see what a winner we can make of this patient if we will just take the time to communicate with her and let her know what impact periodontal treatment and control of diabetes and smoking can have. Before going to patient 3, a word of caution. We've mentioned doing the A1C in the office, and in this patient, we ended up with an A1C score of an 8.6, which is clearly diabetic. But remember, the patient came into our office not diagnosed, and it is certainly not the prerogative of a dentist to make a medical diagnosis, especially on diabetes, because the patient may have a job that is very dependent on dexterity and things like that. And for instance, if you've got a patient that's working on scaffolding or on a high tower or doing something like that, putting that diagnosis on them could actually cost them the job, and we certainly don't want to do that. What you want to do is simply tell them that their blood sugar is elevated and they need to see a physician. Even though you know they're diabetic, let the physician make the diagnosis. Now let's look at patient number 3. This is a 75-year-old male. He is a non-smoker, and he is diabetic but does not know his A1C score, and we do not have that score at the initial appointment. So what we do for a diabetic score, we use an arbitrary score of a 2 until we actually get an A1C score. And the diagnosis on this patient, treatment-focused diagnosis, is a generalized moderate periodontitis in the anterior and premolar areas with a localized severe periodontitis in the molar areas. The patient's significant clinical findings, and I think the first one is very significant, the patient's wife is concerned about the severe halitosis. And I would suggest that you look at the series of videos on disinfecting the mouth using the sodium hypochlorite rinse and the tongue scraper and all, because that would certainly be very applicable in this case. And the patient has had a consult with Clear Choice and wants to know if there is an alternative to removing all of his teeth and doing an implant supported prosthesis. Now let's score patient number 3. Age is a 1, smoking is a dash, diabetes is a 2 because at this initial exam we do not have the A1C score. The molar type is a 1 because we're going to score number 14, and we'll discuss that when we discuss treatment options. Interestingly enough, there's only one furcation on that, and that's a distobuccal furcation. So there's one on furcation. Mobility, we are somewhat concerned about mobility, so that's a 2. So the patient scores a 9. And remember, we talk about a target score or a periodontal report card, and we need to give the patient a target that they can achieve if they have treatment. So let's look at that. Age is not going to change. The patient remains a non-smoker. We did finally have an A1C done, which was a 7.3, so that drops to a 1. Molar type remains a 1. And on the probing depths, you can see that we're getting these down to the 5 millimeter range and perhaps less in the anterior and premolar area. We still have one furcation, and all of a sudden now, after we've done some occlusal adjustment and so forth and reduced inflammation, we're really not concerned about mobility. So now we have a pre-treatment score of a 9 and a target score on our periodontal report card of a 5. And remember the little ditty, if you want to keep your teeth alive, keep the MMPPI score below a 5. And if we go over to the right, if the patient scores a 9, they got a 75% chance of keeping the teeth for 15 years. Or with treatment, they have a 93% chance of keeping the teeth in health for 15 years if they will follow the keys to success. Now, this case can be treated in many, many ways, as you well realize. And that's why we're talking about scoring tooth number 14 rather than tooth number 15. Certainly, you can maintain number 15 if you want to, especially if you're doing laser therapy, or if you're doing perioscopy by eliminating the second molars and only having one furcation and doing a more in-depth job of root planing. Certainly, sacrificing the second molars would not be the wrong thing to do, because we need to keep in mind that the first molar provides 60% function and the premolars provide 10% each. So maintaining a first molar occlusion means the patient will have 80% function. And you and I both know that any 75-year-old who would have 80% of what they had in their 20s is going to accept that treatment. So given all these treatment options, I think you can see the logic of why I scored 14 rather than 15. And certainly the patient deserves the opportunity of hearing treatment options other than the extraction of the teeth, because the logic of treating, I think, is quite apparent on this. So therefore, let's give patients the opportunity of salvaging their teeth in a reasonable degree of health rather than condemning them to extractions. Let's talk about the objectives of clinical treatment. And the first objective is to motivate the patient to accept and complete treatment. Also, this will create new patient referrals. And also, one of the objectives, and I hope you've picked up on that, is to simplify the scoring so that it's so simple to do that a dental assistant or a hygienist can do that without the dentist being present. And to do that, we have to train these people to do it. And that's one of the reasons for having this video made. The importance of smoking cessation. Certainly, smoking has the most negative impact of any of the factors that we're dealing with. For a person that smokes compared with a patient that doesn't smoke, the smoker has a 246% greater chance of losing their teeth. But let's face it, we get paid for performing procedures, not giving advice, so we really do not have the time to actually get into smoking cessation. So you've got a couple of options. One is to refer the patient to 1-800-QUIT-NOW and have them explain it to it. Or you can look at the short video that I have made on that, on smoking cessation, which has proved very, very impactful. And this is the smoking cessation video. It's somewhat corny, but it is effective. And certainly you're free to download that and use it in any fashion that you want. Is the patient guaranteed this level of success? And the answer is no. Because the keys to success are a guideline that if followed by the patient, then they will succeed. But if they do not follow the keys to success, then there is no guarantee, and in all probability the case is going to fail. I've mentioned several times about the importance of cleaning the tongue, and the tongue sweeper that I like is made by Dr. Robert Rippich, which you see here, and the sodium hypochlorite is a short video on how that is used. Also, people using this scoring have noticed a marked impact positively on their staff, because the assistants and the hygienists become a more integral part of the team, because they should be scoring age, smoking, and diabetes actually before the dentist sees the patient. It also adds prestige to their job description because they become more important in the eyes of the patient. And this enables them to better answer questions that the patient might ask, which in the long run could save the dentist time. Additional positives. I think it fulfills a moral and ethical responsibility in treatment planning to enable the patient to select the treatment best suiting their needs. Second, in the future, I think we're going to be required by HIPAA to give treatment options with fees, times, and so forth, and the patient in the future is going to be much better informed in making treatment decisions. The conclusions. Scoring markedly motivates patients to accept treatment. Number 2, it's fast, simple, and easy to score. It increases patient referrals, for the patient should leave the office not only with their score sheet, but also some blank score sheets that they can share with family and friends. And it proves that many teeth that we initially thought were hopeless are in fact treatable. And it proves from a scientific standpoint that teeth with furcation involvement can have a good long-term prognosis. So let's summarize the conclusion. Scoring markedly motivates the patient to accept treatment and gives them a much better understanding of the outcome. It's fast, simple, and easy to score. It increases referrals from patients. It proves that many teeth that we initially thought were hopeless actually have a good prognosis. And it proves that teeth with furcation involvement can have a good long-term prognosis. Now, this is a very dynamic system, and this is the Miller-McEntire score sheet that I used. And you will notice that it has today's score, the target score, and it has post-op scores that can be used to let the patient know what the outcome was. But then Dr. Bob Levine has designed his score sheet, and he was the one that talked about the dental report card. But then again, the final scoring sheet that I'm showing you is Dr. Michael Sonic's, where he actually defines this as your dental report card. Patients like numbers. They like to evaluate how successful they can be. So if you're interested in using this system, certainly you can use one of the modifications of these score sheets or even make up one that suits your needs. But please give the patient the idea of what can be accomplished if they are interested in saving their teeth.